us today for this webinar addressing a very important topic that is dear to the hearts of many of us who are women living with HIV. And I want to extend a special thanks and gratitude to our federal partners who have made themselves available to be on the call today to update all of you on what the federal government is doing to address this critical intersectional issue. And so we're being joined by Lynn Rosenthal, the White House Advisor on Violence Against Women, as well as Maggie Charnogorski, who's the Senior Policy Advisor at the White House Office of National AIDS Policy, Federal Interagency Work Group on HIV, violence against women and girls, and gender-related health disparities. And we also have a number of other fabulous presenters for you today. We have Lindsay Dawson from the Kaiser Family Foundation, who's going to be talking about opportunities within the Affordable Care Act to expand intimate partner violence services to women living with HIV. And we will also be hearing from Gina Brown from Positive Women's Network, and who's also a member of the Presidential Advisory Council on HIV/AIDS, as well as Kat Griffiths, who's a member of Positive Women's Network USA as well. So in terms of how the webinar will run today, I'm just going to give you a little bit of an overview of the agenda. This is what we're doing right now, welcome and overview. We'll hear from Gina Brown, who's really going to sort of situate violence and trauma in the lives of women with HIV. And then we'll hear an update from the White House, followed by an update on the Federal Interagency Working Group on HIV/AIDS, violence against women and girls, and gender-related health disparities. And this working group, as you all probably know, was constituted in 2012 and has been working to address this intersectional issue at the federal level by bringing a number of federal partners together, and just recently released an update report on their first year of progress. And so it's very exciting, and we're really thrilled to be able to bring that to all of you. And I know there's been a ton of interest in the community on the work of that working group. Following that, we'll hear from Lindsay Dawson from the Kaiser Family Foundation, who will go over an analysis that was just released by the Kaiser Family Foundation of the Affordable Care Act and specific opportunities at a policy level, and looking at policy implementation in terms of being able to expand services for women living with HIV as they address intimate partner violence, domestic violence, and hopefully trauma and PTSD as well. And then we're really going to talk about how do we bring this home, from recommendations to action, moving into some advocacy opportunities and next steps. And that section will be led by Kathleen Griffiths and Olivia Ford from PWN USA. And then we'll move into a discussion or Q&A, and we'll have a closing. And you've probably noticed that if for all of the participants on the webinar right now, we can't hear you if you talk. Your lines are all muted. When we move into that discussion Q&A section, we will switch it to a different mode where you can unmute your lines to ask questions. So that'll be towards the end of the call. So please, if you have questions and comments along the way, please do feel free to type them into the chat box. We will be tracking them there as well. But we'll also have some time at the end for folks to verbally ask questions as well. And then we will move through a closing. So I'm going to just start by talking a little bit about how Positive Women's Network USA comes to this issue. And as a woman living with HIV myself, diagnosed with HIV in 2002 and working in this field and having the privilege to coordinate PWN USA, which is a national membership body of women living with HIV, basically doing leadership and building power to transform policies and programs that impact our lives. We have seen violence and trauma play out in so many different ways, and this is the power and control wheel that if you work at all in domestic violence, you're probably quite familiar with. And we actually did one of the things that we realized over the last several years, when we first started doing policy work at our founding in 2008, we adopted a 5-part policy platform looking at care, prevention, economics and employment issues, criminalization, a variety of things, and economic justice. And what we realized as we were doing various aspects of the work in our policy platform was that violence and trauma really intersected with every single one of those. And so we actually ended up adopting addressing violence and trauma as a policy priority because it became so apparent that it was impacting the lives of the women we were working with, their health outcomes, and sometimes even causing death. And so when we did a survey last year on sexual and reproductive health and rights, this is just a little bit of some examples of some of the quotes we heard from that survey. So we were asking women questions about women living with HIV, questions about their sexual and reproductive health and rights, and experiences, perceptions of body image, experiences with sexual health and reproductive issues in care. And these are some of the quotes we heard, you know, everything ranging from feeling ashamed of our bodies, feeling worthless, issues about control in relationships. I was in an abusive relationship for 4 years. My partner threatened to prosecute me under criminalization laws when I wanted to leave the relationship. You know, so really just a lot of ways in which some of these issues, intimidation, coercion, emotional abuse, isolation, were playing out in the lives of women with HIV. And while there's been data, and it's been pretty understood for a while that violence can lead to HIV acquisition and can predispose people to acquiring HIV, what's been less well understood is the many ways in which violence continues to be an ongoing issue in the lives of women with HIV post-diagnosis, and that many times a trauma history continues to play out and manifest in a lot of different ways after diagnosis. And in fact, HIV diagnosis can exacerbate violence and can exacerbate trauma and can create new ways for women to experience violence in their relationships and also institutionally, in terms of policies and structures that place women at risk for violence. So, for example, HIV criminalization laws, which are basically a way of policing sexuality and reproduction of people living with HIV, and therefore a form of institutional violence. So we really came to this and have also been looking at how does this actually intersect with health outcomes for women living with HIV, because that's one of the things we really care about is health, quality of life, rights, and we see them all as very interrelated. And so if you look at the HIV care cascade for women, you see that, you know, we're not doing a great job especially in retaining women in care and keeping women engaged in care as you move on, you know, towards the right side of the care continuum. We see this drop off of 70% to 41%. And if you dig a little deeper and look at some of the data that's been published on intimate partner violence and trauma, it becomes clear that there are lots of ways in which violence and trauma are intersecting with various parts of the care continuum. So there are studies showing that, for example, women who have experienced intimate partner violence are 3 times more likely to wait to be linked to care. So 3 times less likely to meet that within 90-day guideline. That's the threshold. Women who have experienced intimate partner violence are 2 times more likely to be lost to follow-up. They're 2 times more likely to miss gynecological appointments, half as likely to be on antiretroviral therapy, 2 to 3 times less likely to be adherent. And another study that came out in 2012 showed that recent trauma was correlated with 4 times the rate of failing treatment and also 4 times the risk of death among women living with HIV. So this is a study conducted by Dr. Eddie Moxinger at UCSF Women's HIV program, looking at deaths in his clinic, and found that the highest predictor, the highest correlate of death and poor health outcomes among his patients was actually recent trauma or abuse within the last 30 days. And so we really are very honored and really thankful that the federal government has made this issue a priority. We've seen it, we've seen this as women living with HIV, working in the community. We've been seeing this play out in so many different ways anecdotally over the years, and it's just a tremendous step forward and a tremendous amount of progress to have this issue addressed at a federal level. And so what we're going to be talking about today is really some of the work that's been happening at the federal government and what we as advocates can do to continue moving it forward at the local and state level, and to really think about how to translate some of these recommendations that are coming out into policy and practice. And so I'm going to go ahead and turn over to our first speaker today, Gina Brown, who's going to really situate us in understanding the impact of violence and trauma in the lives of women living with HIV. Gina, are you there?
Yes. Hello, everybody.
Great. Thank you.
You can advance the slide.
Okay.
So today we're going to talk a little bit about understanding the intersections between IPV and HIV. With intimate partner violence and trauma, the way it impacts a woman with HIV, it can impact us in a lot of different ways. But one of the most important ways it impacts us is in the care that we access the relationship. And my partner, he did not want me to attend the clinic because he said if people saw me there, they would think he had it. Now, this was a man who had never gotten tested himself. So a lot of times we're hearing, and this is all anecdotal, but we're hearing a lot from women who are saying that they can't go to the clinic because of their partner, or if they go to the clinic, certain things they can't bring home. They may not be able to bring home condoms because of intimate partner violence, or medication. And that may sound a little crazy, like why wouldn't someone want their partner to be on medications? But it's the same thing. If you're taking those HIV meds, then you're going to the pharmacy to get them. If people find out, then they'll also look at me. He can intimidate her in many ways, and the biggest way that they intimidate us is by brainwashing us, which I think we come into it with a little bit of brainwashing already from some trauma we may have experienced in childhood. I can speak from personal experience, being a woman who was molested as a child. I always thought everything was my fault. So when I was given my diagnosis, I immediately thought it was my fault. I deserved this. And he made sure that I never forgot that I deserved it. HIV can lead to an exacerbate IPV in the way that if I'm HIV positive and I go home and I tell my partner and I accuse him of being the one that gave it to me, that can make him go into a violent rage. Or if we're having an argument and all he wants to do is throw in my face about HIV. When we think about intimate partner violence, we're thinking physical violence, but it can be emotional violence also. There's nothing like that mental violence that can tear you down. The people who can play an important role in addressing this are social workers. Number one, social workers have a specific set of skills where they know how to do interviewing and get to the heart of the problem and meet people where they are. Meaning, as a social worker, we pull from your strengths and not your weaknesses. Case managers, the same. Peer advocates. I started in this field as a peer advocate, and I know clients would tell me things that they would never tell their case managers. So a lot of times the peer advocates can be that person that can get this information. And other health professionals can also play an important role in addressing IPV among women living with HIV. Our doctors, our nurses, the pharmacists. One thing I often think about how we can get involved is by listening. Sometimes people say stuff, but you have to really listen to hear. Because for one thing, I didn't want to be looked down upon. And another thing, I thought people would judge me as being the one who caused it because, once again, I've always dealt with that. It's my fault. So I think about other women who are living with HIV and who are in these types of relationships. If they're already coming to you or coming to us with a feeling of it's my fault or I'm blaming me, then us blaming them will make them feel even worse. I try to when my clients come into the room, I never ever say, "Are you in an IPV relationship?" or explain to them what intimate partner violence is. I never talk like that with them. I always say, there's nothing that you cannot tell me. Anything you tell me stays in this room. I'm here to help you get to the next level. A lot of times we don't even know that that it's a problem. I was talking to my daughter the other day, and I was telling her that I was going to be on this webinar and talking about intimate partner violence. And she said, "I remember once you told me that you and my dad used to fight, and I just thought it was normal." And I realized she thought it was normal because I minimized everything. I made it seem normal, and that happens a lot with women living with HIV. We minimize, we take on the blame of something instead of looking at our abuser as the one who's to blame. The last thing I'll say is IPV, although it can impact us, we saw that 85% of women are diagnosed. So that means 15% are not diagnosed. Why aren't they being diagnosed? Is it because the man tells them they can't go get tested? Or is it because they're afraid that if they get tested and they find a relationship? Also, as far as being retained in care, even being virally suppressed, being in an IPV relationship can affect all of those things. I wish that there was a way we could do more research on this, because I think the answers or the solutions we're looking for is out there. We just have to know the right questions to ask. And hopefully women will trust us enough to give us the answers we're looking for. Thank you.
Thank you so much, Gina, for setting the stage. And for anybody who doesn't know Gina already, Gina Brown is a fabulous advocate, a member of Positive Women's Network USA, and an advocate living in New Orleans, Louisiana. And her bio is on the slide deck, which you all saw and which will be available to you after this. Thank you so much for sharing that, Gina. I think it's really, really helpful in framing the many different ways in which a lot of these issues intersect. And so we can't really think about medical care and health outcomes separately from violence, from trauma, from housing status, from employment status, which, by the way, these other things also very much intersect with issues of power and control in relationships. And so if a woman doesn't have safe housing, where is she going to go if she wants to leave an abusive relationship, if she doesn't have a place to stay? And certainly many of the systems that have been set up in terms of people with HIV being able to access benefits have required folks with HIV to keep our incomes under a certain level. And so it can be very hard financially for women to leave violent or abusive relationships as well. And part of this picture is really understanding also a trajectory of trauma and how it plays out in people's lives, and understanding that if we have about half of all people living with HIV touching a system like the Ryan White care system, so about 500,000 people in the U.S. are touching that system every year. And if we know that the rates of trauma in the lives of people with HIV, the rates of PTSD in women living with HIV are estimated to be about 30%, so about a third, which is about 6 times the general population. And many of these folks are accessing care, but they may not be effectively retained in care or engaged in care, but there are opportunities where we can intervene. And so that's some of what we'll be thinking about today as we move through this webinar. The next presenter I want to introduce to you is a very special person. Lynn Rosenthal is the White House Advisor on Violence Against Women. She's one of those amazing people in the White House who comes from community and previously served as the executive director and president of the National Network to End Domestic Violence. She's also run a local DV shelter in North Florida and has been involved in multiple coalitions doing advocacy work and trying to improve services for domestic violence. Lynn has been helping to lead and spearhead the work of this work group since its inception. And besides that, she is just also a really great human being. She came to our Positive Women's Network USA hosted a pre-conference to the International AIDS Conference in 2012, and Lynn came and not only presented but stuck around for about 2 or 2.5 hours after her talk and really listened to and spoke with the women living with HIV who were attending that pre-conference, and has just shown herself time and time again to be a very thoughtful, committed partner. And I think we're so lucky to have people like this working in the highest levels of government championing our issues. I'm going to go ahead and turn this next section over to Lynn to tell us a little bit about what the White House has been doing to address this.
Thank you, Nana, and thank you, Gina. And I want to right back at you, Nana, the incredible leadership that you have shown on bringing women's experiences to our attention. You've played such an important role in influencing all of our efforts, and I think our work at the federal government is only as good as the leadership that we see coming from this community. And I have said to some of you before, and it's absolutely true, that this community has been so effective in raising issues and bringing them forward in a way that everyone can understand and relate to and see as a guiding light to identifying solutions. I was thinking of that as Gina was talking. You know, as always, the people most affected by the problem have the most authentic leadership. And so this partnership between PWN and other community-based organizations and the White House Working Group, I think, is leading to some very significant change in local communities. We also need you all to keep holding us accountable for that. You know, keep bringing to our attention what's working and what's not working. And I know you well enough to know that you will. When the National HIV/AIDS Strategy was in development in 2009, I had really just started at the White House, and it was my first federal job, by the way, so I didn't really know that much about how the federal government worked or how these efforts would unfold. And there are also, by the way, Nana, a lot of people like me who come from community-based work in the administration. It's one of the things the president has really done is bring in people who have some on-the-ground experience. So it's really a credit to President Obama and Vice President Biden that we have folks like me working on these type of issues. But we really looked at this at the time of the National HIV/AIDS Strategy and discussed that we would address these issues very specific to women and trauma in implementation of the strategy. But very soon after the strategy was released, this community came back to us and said, you know, that's really not good enough. We need a very specific focus. Women are bearing a quarter of the brunt of the epidemic. Women make up the majority of new HIV/AIDS infections. Women experience high levels of violence and trauma, and we have to have a specialized response. And people here really heard that, and I have given over the years much credit and will continue to do so to James Albino, who was in the Office of National AIDS Policy at the time, who really took up this charge and brought it to the attention of the White House Council of Women and Girls, who recommended to the president that we develop this work group and that we produce an action plan that would specifically address the intersection of HIV/AIDS and violence against women. As many of you have heard me say, we're doubly committed on these issues. We have not only through our HIV/AIDS strategy a tremendous commitment to turning the tide, but we also have done more to address violence against women than any administration. And that, as I said, is a credit to President Obama and Vice President Biden for their strong leadership in this arena. They're the first administration to ever appoint a White House advisor on violence against women. You're going to hear a lot of data in Lindsay's presentation, so I won't belabor it now, but we know that violence is pervasive in women's lives, that it's more than we even know in our data. All of our survey mechanisms in this area are somewhat flawed, and we know that violence is extensive. Domestic violence, sexual assault, stalking, dating violence, other forms of violence against women are pervasive in women's lives. And so President Obama and Vice President Biden were responding to that when they appointed somebody to work in this area. We took our first steps in 2010 when the president and the vice president announced this unprecedented coordination across federal agencies to address violence against women, and we announced at that time a series of action steps, including training Head Start workers and conducting the first ever White House Roundtable on sexual assault, promoting best practices within the civil justice system, how to better enforce protection orders, for example, and how to include domestic violence in economic empowerment and financial education programs. And we've continued in that vein. I've been particularly very concerned about the rate of domestic violence homicide. 3 women a day are still killed in this country as a result of domestic violence. Multiply that over the years, and you can see the tremendous toll that this takes on women in our country. Even though we've seen a reduction in domestic violence homicides, it's still quite significant, and it's often preventable. And so we've had a real focus on funding local community-based efforts to use evidence-based tools to identify women most at risk of domestic violence homicides and create more immediate interventions. We've got a national domestic violence national domestic violence hotline that responds to 22,000 calls a month. And we've been particularly focused on young women ages 16 to 24 because it's this age group that experiences the highest rates of both intimate partner violence and sexual assault. This is very much violence starts when women are young and continues, as Gina described, really throughout the lifespan. But this key, it starts even younger than this particular age group experience IPV and sexual assault when we look at what Gina raised, and that's the scope of child sexual abuse. So we're looking at it across the lifespan, but we've been particularly focused on teens and young adults. We've looked at how we can use technology to reach teens and young adults in violent relationships, so we expanded the National Dating Abuse Helpline to be available by text and by chat 24 hours a day. The response, by the way, has been overwhelming. The numbers of text and particularly internet-based chats that come into the hotline has really been overwhelming. And of course, most recently, President Obama created the White House Task Force to protect students from sexual assault. And we're very focused on college campuses and how we can address the high rates of sexual assault on college campuses, particularly the predatory use of alcohol to incapacitate women. But I want to say that it was very important to President Obama and also Attorney General Holder and Secretary Duncan that we're not only looking at sexual assault in college communities, but in all of our communities, that we're looking at it in K through 12, and that we're looking at it in young women and girls who may not be in school, the most marginalized and isolated girls within our community. So it was very important. We started with campus, but it's part of a larger effort. So I say all that to say that our commitment to addressing violence against women is very strong. And when the president created this work group to bring these issues together, it was the most heartfelt project that I've been involved in my 5 years in the White House, 5.5 years, I guess, because everybody who sits on this work group has a personal commitment to this issue. Many people have direct experience either with people in their lives or with people that they've worked with in direct services whose lives embody this intersection. Many people saw it in their work as health educators, as nurses, as physicians, as domestic violence advocates, as researchers. And so it is really the most dynamic group that I have been privileged to be involved with during my time. Everybody was eager. Everybody contributed a tremendous amount. So we met for about a year, and we looked at all the good work that was already going on by many of you and other community-based organizations, the research that NIH was undertaking. We heard from many of you in our webinars, folks like Gina, who really brought the intersection, made it real, shared personal experiences that helped us understand the direction we might go. And then we developed the 5 objectives that you see before you. And these objectives have guided our work from the beginning. We want to increase IPV screening and HIV testing for girls and women and encourage concurrent screening. We want to improve outcomes for women in HIV care by addressing violence and trauma. We want to address certain contributing factors that increase the risk of violence for women and girls living with HIV, and by that we specifically meant housing and economic empowerment. You'll hear more about that from Maggie. We wanted to expand public outreach and education and prevention efforts regarding HIV and violence against women and girls, and support better research. And when we think about prevention, I want to say this very much came from all of you and the folks we heard about in our webinars, that we needed to prioritize preventing not only HIV, but preventing violence against women and girls. And to do that, we needed to engage men. And so we've embarked on those efforts as well. So I'm very pleased for today's session for a couple of reasons. One, we'll hear a report from Maggie about our progress and what we've done. I'm also pleased to hear from Lindsay about the ACA and some recommendations to better implement the ACA provisions that support both IPV screening and screening for HIV/AIDS. And I want to say that our plan here is intended to be very dynamic. There are 56 action steps that federal agencies are in the middle of implementing, but our focus could shift according to new information. So when we look at the care cascade, particularly in how women are faring, we may shift what we're focusing on as you all bring us new ideas. It's intended to be a dynamic process. Most of all, it's intended to really make progress in addressing this intersection. You know, when we go around the world, we often talk about the importance of supporting women. We talk about how in our international HIV/AIDS programs, we focus on women because women are so important in their communities, that when a woman is living with HIV, her life affects everyone in the community. She may be caretaker for her children, for parents, for others. Her well-being is central to the well-being of communities. We say that around the world. We don't say it enough here at home. And so that's sort of my new mission in this project, is that the well-being of women is central to the well-being of this nation. And I think this project can play an important part of that. So thank you so much, Nana.
Thank you so much, Lynn. And thank you so much for your ongoing, deep, long-term commitment to this issue, and for being here with us today. So next, we are going to hear an update on what the Federal Interagency Working Group has been doing, a report from the first year of activities, and a little bit of looking for Gorski, the Senior Policy Advisor of the White House Office of National AIDS Policy, who came on board, just a few months ago, and has been really demonstrating her commitment to this issue by just stepping up and keeping the work of this working group going. I think folks know that sometimes when there are transitions in personnel, ongoing projects can, priorities can shift and change. And Maggie has just really shown that she's deeply committed to this issue by staying involved, staying on top of it, making sure this report came out last month, and we are so appreciative of having her here with us today. So Maggie, do you want to go ahead?
Oh, thank you, Nana. And thank you, everyone, for participating in this call today. It's very exciting that we, one, get to share the work that we've done across the federal government with all of you, but two, I really enjoy, and I think it's so important to hear from all of you on how we can do better, because I do think that a lot of great work is being done, but we need constant feedback so that we can best form the policies and programs to address the needs of the community. So thank you very much for holding this webinar. As Nana said, I joined the Office of National AIDS Policy actually in July. I came from the Department of Veterans Affairs, where this intersection is something that I had worked on at the Department of Veterans Affairs. I had joined the Interagency Federal Work Group as a member in 2012, and as a HIV physician and a women's health physician, this is an issue that unfortunately I see in my clinic far too often. So today I am going to give you a little bit of an update on some of the work that has been done across the federal agencies in the last year, and kind of highlight some of the directions that we're looking at going in the future. As Lynn and Nana said, in 2013, the Interagency Federal Work Group put out these 5 recommendations that Lynn just shared with you. But the report in general emphasized the need for coordination and attention to the impact of violence experienced by women and girls on HIV acquisition, as well as how violence influences the health outcomes for women living with HIV. This year, just a few weeks ago in October, the Office of National AIDS Policy, in collaboration with the Office of the Vice President, the Violence Against Women, Lynn Rosenthal's office, and the White House Council on Women and Girls, released our first annual update on the activities going on across the government. And I keep referring to this as our foundational year, but it really was a pretty important year. We had many needed conversations within our own agencies, federal agencies. Often the HIV office and the Women's Health Office are all doing great work, but they're not necessarily always talking to each other. So we had those cross-conversation within agencies. Resources were shared. There was coordination amongst agencies, and we had significant engagement with community partners. I am going to go to the next slide and just highlight some of the great work that was done across the federal government. But as Lynn said, there's 56 action items that we're working on. So I encourage all of you to go to the whitehouse.gov website, the ONAP website, Office of National AIDS Policy website, to download the full report and see all the great work that the agencies are doing. So one of our key highlights is the interagency collaborations that occurred. So one specific collaboration that we are very excited about is between the Department of Justice and the Department of Housing and Urban Development, specifically the HOPWA program in the Department of Housing and Urban Development. These two agencies collaborated in a joint effort to specifically allocate funding and resources to support transitional housing for women who are living with HIV who may be experiencing violence. This project will strategically coordinate the expertise and the resources from 2 federal agencies in an effort to address the housing needs of this extremely vulnerable population, and hopefully will serve as a model for future interagency collaboration. We're very excited about this. Another very exciting advancement was SAMHSA's release of what we call the Trauma-Informed Approaches Conformed Care, or Trauma-Informed Approaches. It's a framework that addresses the trauma experiences and victimization in a woman's life or any patient's life in an aim to help individuals living with HIV modify their negative behaviors and ultimately improve their health outcomes. We are very excited about this. It has been piloted in a number of HIV clinics across the country. It's been shown to be extremely helpful in addressing the needs of women in HIV clinics, and we're hoping to scale that up over the course of the next year. There was also increased attention to testing and linkage to care. We had a number of national awareness campaigns. For example, the CDC put out a campaign called Take Charge, Take the Test, which is a national campaign that encourages HIV testing specifically. It was launched in 10 U.S. cities where Black women represent a significant portion of the epidemic. We're very excited about this. You'll see some other highlights from the report, one of which is increased screening. Gina Brown earlier talked about screening for both HIV and IPV and how important it is. We have had significant progress on this area. For example, the HRSA, or the Health Resources Services Administration, has collaborated with the Administration for Children and Families to disseminate HIV and IPV screening tools to all Ryan White programs, federally qualified health centers, rural health programs, maternal and child health programs, and National Health Service Corps. Something that's not listed on the slide, but the U.S. Department of Veterans Affairs is now screening all women for HIV, actually all veterans for HIV, and has approved IPV screening to begin next year, which we're very excited about. There's been a number of cross-training activities that have gone on. For example, HHS's Office of Women's Health has released what's called the Intersection of Violence Against Women, a cross-training guide for providers, which is really focusing on educating and training not only violence prevention caseworkers, but also HIV caseworkers on the link between violence and HIV/AIDS. the guide is really going to be used to train a number of people across the system, counselors to promote HIV testing and HIV risk reduction counseling in their service delivery, as well as to train HIV service providers on how and where to refer clients for IPV services. On the next slide, there's just a couple of other highlights that I want to point out. For example, there's been work that's being done on the LGBT for the LGBT populations out there. ACF, for example, funded the Northwest Network of the LGBTQ Domestic Violence Learning Center and partnered with the National Coalition of Anti-Violence Programs and AIDS Institute to develop outreach materials addressing the intersection of IPV and HIV. And the NIH is doing a lot of work in this area. We're really excited. For example, the Women's Interagency HIV Study, or otherwise known as the WISE study, expanded to include sites in the southern U.S., which more accurately kind of represents the epidemic among women. In addition, the WISE investigators have published a number of papers that were in 2014 that analyzed the psychological factors, sexual minority status, and gender-based violence of HIV-infected and uninfected women at risk. So we're really excited about all this work, and the 2014 update report really shows some promising trends and kind of first steps towards addressing the needs of women who face both IPV and HIV infection. But, you know, this is just the first steps. We really have put out a call to continued action and to continue momentum into the future around this topic. So some of the next steps that we talk about in the report is kind of a focused effort around three things. One is increasing screening for both IPV and HIV, not only in primary care clinics, but for IPV screening and HIV clinics. We know that some is going on, but I think asking the questions and getting our providers to be able to discuss this with their patients is a key first step. Two, we talked about the trauma-informed care approach just a few minutes ago. We really want to focus on scaling that up in HIV clinics to address the violence in women's lives and try to have a bigger impact on health outcomes. And the third is to really expand outreach and prevention efforts to young girls of color and communities with high rates of HIV. As Lynn said, you know, I think focusing, making sure that women know that they are important. We do say that more internationally than I think we do here domestically, but they matter. They are core and central components of families, of communities. We want to expand our outreach to really reach young women and girls at an early age and develop confidence and empowerment and give them opportunities, both educational and economic, to really kind of help them thrive in life and give them the confidence to make good decisions when they're faced with challenges in life. Overall, the report identifies some cross-cutting challenges, biological, social, socio-cultural, and economic, that impact HIV and IPV epidemics. But I'm excited. The report really shows that we had a pretty tremendous year. We achieved foundational planning, created new connections, fostered some implementation. But I'm really excited about the coming year. I really think we are going to have even greater advances and more collaborations. And I'm hoping to have a tremendous impact at the community level. So I really hope that all of you can help us keep up the momentum and keep this work going. Thank you.
Great. Thank you so much, Maggie, for that really fantastic overview and the report on the incredible amount of work that's been happening to date. I know you called it a foundational year, but obviously so much has been going on already, and I know that we're particularly encouraged to see the housing focus, the focus on creating housing for women living with HIV who have experienced violence, and of course the trauma-informed care piece as well. So critical. So thank you. Next up, we're going to hear from Lindsay Dawson from Kaiser Family Foundation. And Lindsay is the mastermind behind this amazing resource that was just released in October during Domestic Violence Awareness Month. That's really an incredible tool for all of us as advocates to use in thinking about how do we really take these recommendations and guidelines and the problems that we're aware of, and how do we really translate this all into action on the ground, at the local level, at the state level. And so Lindsay worked on, basically conducting an analysis of the Affordable Care Act to say, where do we have opportunities given this new legislation and the way that the policy is being shaped and implemented? How can we actually impact and increase access to IPV services for women living with HIV in that light? So Lindsay is going to go ahead and walk us through an update on that and a little bit of kind of framing in terms of the data and statistics as well.
Great. Well, thank you so much. Good afternoon, everyone. It's such a pleasure to be here and to be among these other really fantastic speakers. As Nana mentioned, what I'll be talking about is really a quick and dirty version of the report, which goes into more detail about the opportunities under the Affordable Care Act that could be there to address intimate partner violence. And we framed it in a way to really think about how those might impact women living with HIV who are experiencing or at risk for intimate partner violence. So I'll provide a little bit of context, even though I think some of the other speakers have begun to do that in a really nice way. Then look at the opportunities and sum up by looking at where we might be in terms of implementation and where there might be steps to take in the future. So in terms of the scope of the problem, as we've discussed, violence against women sort of across the United States is widespread. 27% of U.S. women report ever having experienced unwanted sexual contact, and 36% of U.S. women report having experienced IPV that includes rape, physical violence, and stalking. And when we extend to other experiences and other behaviors, that percentage is much greater, of course. But the experience of violence is even greater among HIV-positive women. It's more widespread. It's estimated that 55% of women living with HIV have experienced IPV. And intimate partner violence is also associated with trauma, which in turn is associated with poor treatment outcomes and higher HIV transmission risk. And so I think what this does is it creates an opportunity for us to think about how addressing intimate partner violence is part of addressing HIV for women in the United States. These are statistics that I've already been over, but I think it's kind of a nice display showing the increased experience of IPV among HIV-positive women in the United States. And at the beginning, I think Gina did a really nice job about talking about the intersection of intimate partner violence and HIV positivity. We tried to think about it as a cycle for the report, that being at risk for HIV put you at risk for HIV infection, which put you at risk for experiencing IPV, and similarly, experiencing IPV put you at risk for HIV. It was found that women in violent relationships are at 4 times the increased risk, including HIV, than those in non-violent relationships. And one study found that 20% of HIV-positive experience violence by a partner or someone important to them after their diagnosis, with half associating that violence specifically with HIV diagnosis. I'm going to turn to talk about the specific opportunities under the ACA, but before I do that, I think it's important to consider the mass coverage expansions that have happened with the Affordable Care Act. Because, of course, gaining access to coverage is gaining access to the health system, which is where these opportunities lie. So more than 8 million individuals signed up for a marketplace plan last year, and the CBO estimates that an additional 5 million individuals got coverage outside of the marketplace, but that was ACA compliant. In addition to that, 6.7 million more individuals were determined eligible for Medicaid than before open enrollment, which is it's a proxy for those enrolled in Medicaid as a result of the ACA, though it does include some others. And I think it's important to remember that coverage does vary based on a couple of things, and based on many things, but it varies in the private market and it varies with respect to Medicaid expansion decisions most significantly. States are allowed to make benchmark decisions, which essentially guide what plans look like in terms of coverage in the individual and small group markets. So state decisions around that, and then of course individual plan benefits really make up what types of coverage some individuals have. I think more significantly, though, are the state Medicaid expansion decisions. The Affordable Care Act envisions that all states would expand their program to include individuals up to 138% of the federal poverty level, which is just under $15,000 a year for an individual. But the Supreme Court decision effectively makes this a state option. This map shows where states are in terms of that decision. The orange states are states that are not moving forward with Medicaid expansion at this time, and the dark blue states are states where they are implementing expansion. The lighter blue states are not moving forward at this time, but they're open for debate and look like they might be moving forward with some form of a Medicaid expansion. But I think importantly, 42% of HIV-positive women live in states that are not expanding. And given that we know HIV positivity and the experience of intimate partner violence trends with poverty, lack of access to care could be very significant for these individuals. Looking now at the specific opportunities under the ACA. First, the ACA eliminates the pre-existing condition exclusions that were so common beforehand. It eliminates rate setting based on health as well. So this means that no longer can somebody be charged more, have their coverage rescinded, that means having their coverage taken away, or be denied coverage because they're HIV positive, because they're an IPV survivor. Similarly, these protections apply to gender as well, or any other health status. Prior to the ACA, many people with HIV were denied access to the private market or were offered coverage, but that coverage was so expensive it was cost prohibitive. And prior to the ACA as well, 7 states explicitly permitted insurers to deny coverage to survivors, while 22 had IPV anti-discrimination protections in place. Additionally, the ACA provides access to a range of no-cost preventative services for women, including screening and counseling for intimate partner violence. And most private health plans and all Medicaid expansion plans in states that expand will be required to cover this. There's no requirement right now for the traditional state Medicaid programs that existed before the ACA, and of course, as I mentioned, not all states are expanding their programs. In addition, the ACA, as you may know, has an individual mandate. It means that most people do have to have some form of coverage, but there are exceptions to that. And one of the exceptions is individuals who have recently experienced IPV. So somebody who has experienced IPV fills out a form, but they do not need to document any other reason why, so they don't need to provide medical records or anything like that as to why they can't get coverage. But on the form, it is asked that you explain what the hardship is that prevents you from gaining coverage. In addition, the ACA guidance related to the ACA allows married IPV survivors to file taxes separately from their spouse and still claim a tax credit. So I'm going to break that down a little bit. Tax credits are available under the ACA for those between 100 and 400% of the federal poverty level, and those help to reduce the monthly cost of plans, so it reduces the premium for people who are purchasing plans in the marketplace. Typically, to be able to have that tax credit, a married individual has to file their taxes jointly. But recognizing that an IPV survivor might not be able to interact with an abuser in order to gain access to these tax credits when applying on the marketplace, and might be filing their taxes separately, there's a protection there that allows somebody to file separately and still gain access to these important subsidies. This is limited to 3 years, and it's a temporary rule that's in place right now, meaning that this is sort of the rule for now, but we're still waiting for that to be finalized. And the comment period on that ended earlier this month. That rule that I just described around the ability to file your taxes separately and still access the subsidies was issued quite late in the open enrollment period. And so to account for that, there was a special enrollment period available for survivors of IPV in the federal marketplaces so that individuals could take advantage of that. It was an option in state marketplaces, and that is closed now. It closed in May of 2014. Another really important thing that the ACA does is that it creates more access to mental health and substance use services, which is really significant because experience with both HIV and IPV are associated with increased mental health and substance use comorbidities. And in the past, many plans did not cover these types of care. It was estimated that 1/3 of those in the private market lacked substance use coverage and 20% lacked mental health coverage. So the law includes mental health and substance use services as one of the 10 essential health benefit categories, which are categories of benefits that individual and small group plans and Medicaid expansion plans need to include as a benefit in their benefit package. And those benefits have to be covered in the same way, sort of in the same scope that medical and surgical benefits have to be covered. I'm going to go over a few more opportunities in the ACA, and these are not directed at individuals, but they're sort of broader. The first two are state grant opportunities. So there are competitive grants under the Pregnancy Assistance Fund, and those are funds that can provide intervention and support services for pregnant women who are victims of domestic violence, sexual violence, or stalking, or they can be used for federal, state, local, and other partners on these topics. There's also the Maternal, Infant, Early Childhood Home Visitation Initiative, and those are formula and competitive grants for states through 2015, and those provide resources to address families at risk in at-risk communities. And there's specifically a provision to allow those funds to be extended to address domestic violence. States going through with a formula grant also have to show a reduction in crime or domestic violence. And I think these two initiatives really demonstrate an alternative setting where IPV can be addressed and are particularly relevant to women who are mothers. And given that we know so many HIV-positive women are in fact mothers, could provide a potentially new avenue to address intimate partner violence. Finally, the ACA also establishes the National Prevention Council and calls for the National Prevention Strategy, in that injury and violence-free living is named as a priority area with specific references to IPV. And it recommends that the federal government research and disseminate effective methods to prevent IPV. So now looking sort of forward and thinking about implementation issues, I think it's really important to consider what Maggie talked about in terms of whether domestic violence screening is happening as often as it should be. We know that coverage doesn't always equate with uptake or it being offered by a provider. A recent Kaiser Family Foundation survey found that 23% of women aged 15 to 44 have had a discussion with their provider around dating or domestic violence in the last 3 years. So it is happening for some, but it certainly isn't widespread. And there may be a need to address and raise this issue sort of with providers more broadly about how to best do provider-led screenings. Additionally, awareness might need to be raised around the intersection of HIV and IPV for providers. I think as we consider individuals moving into the private insurance market, it's also important to think about confidentiality. Private insurance plans typically send an explanation of benefits out, or an EOB, and those document the services that have been provided, and those often go to the principal policy holder, such as a spouse. Or they might just be a document going to an individual if they're insured on their own, but it is a document that could sort of be in the home and potentially disclose that a screening had been provided. I think it's also really important to consider ongoing rulemaking and state decisions that are taking place that are specific to intimate partner violence, including the finalizing of that tax rule that I had talked about earlier. Whether or not future special enrollment periods take place. And I should have mentioned earlier, but a special enrollment period essentially means a period when somebody can enroll in coverage outside of the open enrollment period. Also, state-based exchanges, as I mentioned, can make their own decisions in a number of ways, including with special enrollment periods. And states can decide whether or not to move ahead with these grant opportunities. There's also ongoing rulemaking and state decisions that are taking place that are more general but really relevant. I think the largest is probably Medicaid Expansion, And then there's additional access opportunities that will need to be assessed because coverage is going to vary by payer. So traditional state Medicaid plans don't cover some of the provisions that I've talked about, and employer-sponsored plans also. And ultimately, the impact of these provisions is really yet to be seen. The ACA sort of lays the groundwork and presents these opportunities to address intimate partner violence for women living with HIV and at risk for HIV, but we sort of need to see how that's implemented. And I also think it raises sort of the opportunity to see how addressing intimate partner violence can be part of the national strategy to address the HIV epidemic. So thank you very much.
Great. Thank you so much for that, Lindsay, and really for that level of detail and precision about how we can move some of this forward, I think is enormously helpful. And your point about a national strategy to address HIV, really needing to address some of these other issues, including IPV and trauma, as they're impacting health outcomes and as they impact prevention, is so critical and is particularly salient. So thank you so much. And I do want to let folks know that we have a link to the full fact sheet later in the slide deck, and that will be made available to all of you after the webinar as well. It's a really fantastic resource. So next up, we are going to hear from Kat Griffiths, who is a board member of Positive Women's Network USA. She's also holds a master's in social work and currently works in a residential addiction treatment program for women. And Kat has been involved with PWN USA and has also been involved with addressing these intersectional issues at a policy level in her state and nationally in terms of programs and developing an intervention for a while. I'm going to go ahead and turn this over to Kat.
Hi. I just wanted to start off by saying that I am incredibly honored to play a role in this very important conversation. I'm really excited about the fact that this issue has gained traction. It's obvious by the attendance of this webinar that this is an issue that is important, not just to women living with HIV, but to care providers and people at all levels of decision making. So first, I want to give you a little bit of context. I'm a woman who's been living with HIV for 23 years. I was in an abusive relationship in high school, which is not the relationship that I acquired HIV, but that set me up perfectly for doing so later. And as Nana mentioned, I'm currently working in addictions where I get to see the effects of trauma and violence every day. How I came into this work was in 2010 when I was asked to sit on an advisory committee for the National Network to End Domestic Violence. And we were charged with creating a cross-training curriculum between domestic violence providers and providers of HIV services. I was able to participate on a panel at the 2012 International AIDS Conference in DC for a press conference on this intersection. And that was a really exciting time because that was kind of the moment when the research was really starting to come out. And then both in February and in October of this year, I was honored to participate in meetings with federal partners and to be there for the Interagency Working Group's public release of their first report. And that was sponsored by AIDS United. Through a national level advocacy from PWN and other community partners, the last couple of years have seen a significant increase in attention and research, much of which you have heard about today. But what I began to notice that my own state and my local AIDS service agency were not addressing violence and trauma at any level, either from state funding to state grants to programs at the ground level. Through an ongoing 2-plus-year process, I have advocated to state officials in an attempt to put violence and trauma on their radar. It has been quite a process, and there's been a lot of resistance from individuals, specifically when it comes to prevention grants and scopes for the state of Illinois regarding HIV acquisition. But as we've heard today, the reality is that women living with HIV experience a much higher rate of violence and trauma overall compared to the rest of the population. And there's also plenty of information that shows a direct correlation between violence and trauma and poor outcomes for women living with HIV. So how do we go forward? There are plenty of opportunities for advocacy. And I want to point out initially that in each example, there are opportunities for collaboration at all levels, and early identification of allies is always helpful in any advocacy process. So when you look at the programmatic or agency level, first you need to know if screenings for IPV and trauma are even in place. And when they are, expanding those screenings is paramount. If they don't exist, that is an opportunity for advocacy. We know that many women living with HIV are not being served in a trauma-informed setting, and there are a few, and so for those that do exist, trauma-informed care must be scaled up. An opportunity for collaboration exists between HIV and mental health, substance use, and as Lynn mentioned earlier, sexual assault coalitions, any organization that would be willing to seek out trainings on trauma, PTSD, and violence. So what can this look like? Agencies can have cross-trainings, such as the NNEDB curriculum that I was part of creating, or, as Maggie mentioned earlier, from the Office of Women's Health, the curriculum that they have put out. And PWN and the UC San Francisco Women's Health HIV Clinic has partnered to do a pilot study on creating a trauma-informed primary care clinic for women living with HIV. So at a community and state level, it's important to gain knowledge of funding and programmatic priorities that are being set by the plan groups around the state. For instance, what is the focus of the grants? A critical question always is to ask who is being left out. What opportunities exist for educating those at the decision-making tables about the intersection of violence and trauma and women who live with HIV? It is essential to expand partnerships between HIV service providers and domestic violence state-level coalitions, and that's just an example. So another example of what this can look like. Last week at the Illinois STD HIV conference, I was privileged to co-facilitate a session on addressing the intersection of violence and trauma in the lives of women living with HIV. And I partnered with Vicki Smith, who is the Executive Director of the Illinois Coalition Against Domestic Violence, and Ebony Turk, who is the Coordinator of Community Programs at the University of Chicago Medical Center. So again, I want to point out that a key in all of this is identifying champions and allies. So the way forward, obviously, as many of the presenters before me have talked about, changing policies. Criminalization laws disproportionately affect women and are often used as a tactic to control a woman, to keep her in a relationship, or are used against her if she chooses to leave. It is important to push for the elimination of laws that criminalize sex work, notably those that criminalize possession of condoms. Ultimately, we need metrics on addressing trauma and violence in the lives of women living with HIV in federal and state policies, as well as tracking health outcomes in the clinic setting. And finally, we must ensure that we continue to push for ACA implementation and Medicaid expansion to include coverage of relevant services. So I will close by saying that my advocacy story highlights the need to be aware of what kinds of decisions are being made. There are opportunities at every level of care and prevention. Is there an opportunity to advocate with agencies that provide services outside of HIV but that might be relevant to the intersection, such as a DV provider or a sexual assault provider? What kinds of grants are coming through the states or the CDC, and what are the scopes for your region or your county? Who delivers those grants, and what kinds of screening tools are being utilized? For example, screenings are not happening in a broad scale in Illinois, and conversations around the country tell me that they are not happening nationwide with women living with HIV. There are some models being utilized by individual agencies in some places, but there is no standardized approach to addressing this intersection. We now have recommendations from the Federal Interagency Working Group, and that gives us a tool with which to advocate, and now we have the Kaiser report as well. And so I personally hope that we will utilize both of those documents and really push this issue forward. So thank you for including me, and with that, I will turn it over to Olivia Ford, who is the Communications Director for the Positive Women's Network.
Hello, everyone. Thank you so much, Kat, for that really phenomenal presentation and sharing some opportunities for folks to get involved in this really vital aspect of advocacy. I hope everyone can hear me. This is my first time actually speaking on the webinar, so I hope that everyone can hear me. I'm going to keep this brief because I want to make sure that we have a lot of time for discussion and conversation. But I just wanted to take a moment to, first of all, talk about the National Day of Action to End Violence Against Women Living with HIV, which was convened just a couple of weeks ago. And I just want to take this opportunity to heartily thank everyone who's on the call right now and anyone who's connected to someone who was involved in making this Day of Action a reality. I know that there are many folks on the call who were part of the development of the Day of Action, who shared messaging, who planned events on the day of and around that day, really for the whole week, as part of Intimate Partner Violence Awareness Month. And I really just want to take this opportunity to thank you yet again. It was in every way a community effort and a really, really exciting one. I've heard the term momentum a lot on this call and on this webinar, and I'll show you in just a few minutes how this Day of Action really showed how there's significant momentum around addressing and breaking the connection between. So yes, again, just a little bit of background on the Day of Action. It just happened a few weeks ago on October 23rd. It really originated from, the idea for the actual day originated from organizing that was happening in Texas around the murders of Cicely Bolden and Alicia Henson in that state 2 years apart from each other. And of course, as we know, these are two cases of the brutal murders of young women living with HIV due to their disclosure of their HIV status. These are ones that got media attention. These are ones that we know about, and really, but we also know anecdotally that there are many more cases like this. And the Day of Action really brought that forth and gave folks in communities opportunities to share the names of IPV and have not survived. But yeah, so in the lead up to the Day of Action and on October 23rd, there were in-person events, there were online activities, there were vigils and protests, ruckus raisings all around the U.S. There was a really incredibly powerful flash blog organized by advocates in Houston, members and allies of PWN USA, that had some really painful and really powerful entries from women living with HIV who've experienced intimate partner violence, or who are impacted by HIV and intimate partner violence in their lives and in their work. In advance of the day, we shared an array of sample tweets, Facebook posts for our allies and partners to share as part of the day as well, to really create kind of an avalanche of messaging around breaking the culture of violence against women living with HIV and all women. A hashtag on Twitter, if you're familiar with Twitter hashtags, that was used throughout the day was End VAW-HIV, or End Violence Against Women with HIV. And that messaging was shared hundreds and hundreds of times over social media throughout the day. We had 20 organizational endorsers. It was really exciting to partner with and work with folks both within the HIV community, existing allies, and really begin to forge connections with partners and allies around this day outside of the HIV community sphere. We work with anti-violence organizations, of course, the National Network to End Domestic Violence, which Kat and others have mentioned, of course, is committed to this issue as well, and did a Twitter chat on October 21st around the intersections of intimate partner violence and HIV. They were also endorsers of the day. And not just our endorsers, but dozens more organizations and individuals were sharing this messaging and these resources on social media. They were inspiring blog entries among their own constituencies of their organizations, around this intersection and the importance of addressing it. So it was really powerful to witness. And of course, there was also media coverage, several really strong pieces in HIV Plus magazine. Edge Boston also covered today, and there are several more pieces to come as well that are connected to not just the Day of Action in and of itself, but the intersection of intimate partner violence and trauma in the lives of women living with HIV. So again, this day just was a powerful awareness building opportunity and really a chance to show that there is support and momentum around addressing this powerful and vital issue in the lives of women living with HIV and those impacted by HIV. I just wanted to take a minute to thank our Day of Action endorsers in this very visually busy slide. But it really was an amazing experience to be part of. And again, thank you everyone who was involved, who is on the call here, and anyone within the sound of my voice who was part of that effort. And
Great.
with that, I'm going to turn it back over to Nana. Mm-hmm.
Thank you so much, Olivia, for walking us through that. And I think, we were really inspired and heartened to see the tremendous community response and the tremendous support for this new National Day of Action that was really called by women living with HIV who said, enough is enough. And, we're here, we want to be involved in all the activities around domestic violence awareness and intimate partner violence awareness, but we specifically are calling for a day that is focused on the unique ways in which violence is impacting women living with HIV. And it was really, it really came out of these heartbreaking, devastating murders that ended up making national media, but that just represents something that we know is going on in our communities among women we know, often in the shadows much of the time. And so we're committed to moving this Day of Action forward and continuing it. You will be hearing from us that will be even bigger, even better. What we want to transition into now is a little bit of a discussion with you all, and I know that folks have already been chiming in on the chat box. We want to hear from you about what you are working on in terms of moving some of these recommendations forward, what's working, any challenges that you're facing, resources that you might be looking for in helping to really move these federal recommendations into action and these advocacy and policy opportunities into action at the both at a policy level, at the local and state level, and also at a programmatic level. So I know a lot of folks have been talking about different kinds of advocacy they're engaging in. So what I'm going to go ahead and do is change our audio settings so that people can ask questions.
All attendees are muted and may unmute themselves by pressing *6.
So if anybody has questions, you're welcome to press *6 and unmute yourselves. Questions for the presenters or strategies that you've been using to move us forward that you want to share, that you think are a great resource. We've already been hearing from a number of folks on the chat box who have been sharing some strategies and ideas and challenges. So I'm going to go ahead and just see if there's anybody who wants to chime in. And while we wait for folks to come off mute, there was one question that came up earlier in the webinar, which was Heather Forner from San Francisco was asking about any data that might be available on the ways in which HIV diagnosis impacts transgender women in terms of violence. And I was wondering if any of the presenters have information on that for us or could point us to resources.
This is Lindsay. Heather, I would have to go back and double check it for you. But the researcher Nana mentioned earlier, Dr. Machtinger, did an article that came out the same time as the one she referenced. And that was about antiretroviral failure. It was about trauma associated with ART failure and transmission risk. among HIV-positive women and transgendered women, and I believe that there were about 30% transgender women in that study. If you want to shoot me an email, I will be happy to find the citation, or you can find it in the Kaiser report.
Great. Thank you so much.
And I believe the finding was that there wasn't a difference between transgender women and biological women.
Thank you. Any questions or comments coming in on the phone? *6 again to unmute your line.
My name is Renee Perkins, and I'm from Colorado Springs.
Oh, Renee, could you speak up a little bit? It's a little hard to hear you.
Let me get a mic. Can you? Is this much better?
Yeah, that's better. Thank you. Yep.
So I had just posted that this is something I was not aware of, that HIV women were even going through or experiencing this violence. This is so new to me, and I'm glad that I was able to get this email about this presentation. So I have learned. I just recently got appointed to a position as an HIV network coordinator, and I'll be doing HIV testing. And some of the questions I know that I have to ask some people, this right here has just really opened my eyes, because I would have never even thought about anything like this, why some people would have never got tested because their partners or somebody was threatening them physically or with violence. So this has been a great presentation for me, because I was never aware of this problem.
Renee, this is Lynn. I would just add that as you start to reach out to domestic violence advocates, they'll be helpful to you, because as they understand this whole cycle of power and control, it then becomes clear how all of it can affect HIV management. So I think that will be useful for you to reach out to those folks.
Exactly, and I know that I'm going to definitely be speaking to my executive director. She didn't know that I was going to be partaking of this, because I just did this on my own. But I'm definitely going to bring this up. I know they have a women's empowerment group that they meet every other Thursday, and I'm definitely going to ask questions about this, because, like I said, I just feel like I'm like out of the loop. I thought I was aware of some things, but this area right here, I definitely feel like I did not know anything about it.
Mm-hmm. Great. Thank you. Any other questions on the phone line? Oh, there's a question that came in on the chat box. I'm interested in understanding how IPV screening could be integrated into our HIV testing efforts. This is Emmeline, who says she is a public health nurse working in TB control, refugee health, and the STI HIV program. So I don't know if anybody has responses to that. We actually had some messages earlier on the chat box about folks who felt like they were having challenges figuring out how to integrate IPV screening into HIV care and services. So if any of the presenters could speak to that, that would be great.
So this is Maggie Charnogorski. Now, there's a lot of different approaches that you can take to this, to screening for HIV and IPV in different kinds of clinical settings. So it kind of depends is the answer, whether you're in primary care or if you're in family planning clinics. I think the example you gave is somebody's in a public health clinic, an HIV public health clinic. There are tools and resources available for different kind of screening tools on the womenshealth.gov website, which is HHS's Women's Health website, and also the ACA IPV screening tools that can help provide guidance for you on what questions to ask and what responses would trigger you to do further questioning. So the answer is it kind of depends, but there's a lot of different options, and there's a lot of different tools out there that can help you kind of guide your way. So if people are interested in learning more, feel free to shoot me an email, and I can connect you with some of those resources.
Thank you so much, Maggie. So we just have a few minutes left, and what I'm going to do is see if our presenters have any closing comments, and then go into talk about some next steps as we close out. So any of the presenters want to add any closing comments before we close out?
Sure, this is Kat. I think one of the things that I really learned in that being part of that advisory committee through NNADB was we initially came together for one day and realized at the end of one day that it was going to take a whole lot more. And so there's a lot to be learned from each other and about how each type of agency, each type of practitioner works and what their focus is. But it's been such a huge learning curve and such a great learning opportunity for me. And so what I would encourage anyone to do, if you're in an agency, get a training in. I think it's a really great opportunity for entire agencies to learn together. That would be one thing. And this is just one of many steps that we're going to be taking. I know my work is going to continue. So that would be my biggest suggestion for people is if you have access to those trainings, if you have access to bringing one in, then do so.
Yeah, I think that's right, Kat. This is Lynn. I mean, we really did see in our work group that that these fields were sort of working, we're not working together. So there's all this capacity to address violence against women and all this capacity to think about HIV/AIDS in women, but they weren't coming together. I think NNEDV's curriculum is one great project that does do that, and that's what we would encourage people to do at the local level, is to build those relationships with the domestic violence provider and the Rape Crisis Center, and it will make everybody's job easier to do because the capacity to address both issues is so important.
Thank you. Any other recommendations from presenters?
Yeah, this is Lauren out in California, and I just wanted to say that as part of our Ryan White Part A Planning Council, we have put it in we have a document called the How Best to Deliver Services document, and it will be, IPV screening will be in that document for contracts that go out for people seeking Ryan White funds for services for next year. I think the issue is, again, that, there is no actual training or curriculum available for different providers to provide the service once they get past the screening. And again, I think it's important that we did at least provide a way for service providers to get funded to pay expert counselors and that kind of thing to provide the service. Because we can never forget that for people that are reliable on funding, and especially government funding, if there isn't a mandate for that funding, then the service doesn't get provided. It just gets talked about.
Great. Thank you, Lauren. So just in our last minute or two, any of the other presenters want to make recommendations before we close out for today?
This is Lindsay. I just think one thing that came across really clearly in this webinar is that we had our federal partners speak, and we had folks who are doing work on the ground speak, and then I presented opportunities under the ACA, is that there's often a gap between policy and practice. And it's my job to sort of think about policy and describe the opportunities under the ACA, but it's the folks on the call who can understand those opportunities and take advantage of them.
Mm-hmm. Thank you, Lindsay. Well, hearing no other comments from our presenters, I want to, I know that a lot of folks chimed in with examples of work that is happening and some strategies that you all were sharing with each other on the chat box, which I thought was incredibly powerful. And so what I want to offer as a follow-up is if folks are interested, and we'll send a survey out to attendees afterwards to see if you'd be interested in this. If folks are interested, we will convene a follow-up webinar that focuses on a couple of case studies of people who are trying to move this work forward in different ways, whether it's at an organizational level, a clinic level, or an advocacy level, so that you all can kind of start strategizing together and learning from each other, and we can start sharing some best practices. And before we close out, I really want to thank all of our presenters who are just fantastic, you know, from sharing your personal experiences to your deep commitment and your expertise. We can't do this work without each other, and it is so important that we have, you know, the research that drives our ability to make the case as advocates. It is so important that we have people in decision-making positions who make themselves accessible and who are committed to keeping this work moving forward. And this is a tremendous community collaboration, and I think we all see that while a lot of progress has been made, there is much more to do. And I know that from our perspective as PWN USA, we're committed to helping to that space and keep this work moving forward. So I just really want to thank, again, all of our presenters for your participation, all of our participants for engaging so thoughtfully and sharing your experiences and your lessons learned as well with us. And we look forward to connecting with all of you again soon. Have a great weekend, everybody. Thank you.
Thank you.
Thank you.
Thanks.
Thank you so much.